Respected judges and my dear friends. In our country, every year, more than 35 lakh babies are born preterm. Even in the utopian situation where we imagine all these babies are going to be screened for ROP, it means more than 17 million ROP exams. For this rural baby from Gulbarga, it would mean 5 visits of 250 kilometers each, only to be told that she does not have ROP. The problem is, ROP is truly multifactorial, and we still don't know how to predict which baby will get the disease and which won't. Some low-cost prediction models that we've developed for rural Karnataka are good, but they're not good enough, because we still can't predict which baby will have the disease in the first visit, and hence the elusive search of the so-called biomarker. Why not use tears, we asked. After all, tears are being used as biomarkers in systemic conditions and even in adult ocular diseases, as you've been seeing. In the past few years, the number of publications that you see in adult ocular disease and others is dramatically rising. But infants, tears, biomarkers, and ROP, well, none. And that's why this novel study, where first of all, can we even detect these antigens in the tears of a few-week-old babies, and then go on to actually predict which babies will have the disease based on what we find? 39 infants undergoing ROP exam were the subjects. As they were undergoing ROP examinations, multiple visits, tears were collected with a Sherma strip, at least to a length of 20 millimeters. And then they were taken through the cold chain into the cryofreezer of our laboratory, where they were archived and analyzed. The Sherma strips are cut into really tiny pieces and put into these chest tubes, and they are agitated with PBS solution at 4 degrees for about 2 hours. The analyte is then taken, where we add these beads. Each bead is an antibody for an antigen we're interested in viewing, and multiple antigens can be detected in a small analyte at the same time. Finally, the reading comes out of this device, the flow cytometer, which not only tells us what it is, but how much we have. Now, these are the 10 antigens we were interested in. Now, these are literally Greek and Latin to us. So let's look at it as 4 families. The first family causes the blood vessels to grow. The second one is a sort of a attractant of cells to that process. The third one communicates between these cells, and the fourth causes adhesions. Now, let's look at these results as a clinician would rather than a scientist or even a statistician. This animation shows us what happens to those babies who started off with no ROP and ended with no ROP. In other words, the controls, where the vessels were completely to the ora. In their first visit, when we didn't know what was going to happen to them, we had higher levels of VEGF, angiogenin, and these factors. In the second group, these babies had no disease to begin with in the first visit, but after a few weeks developed what we call mild ROP or type 2 ROP. Now, in them, in the first visit, when we had no idea what's going to happen to them, we had lower values of these, especially the VEGF and angiogenin. A third group progressed from the so-called mild ROP to a severe ROP, which we call type 1, which requires laser therapy. Now, interestingly, in the first visit, when no one had a clue that these babies would eventually reach there, we had higher levels of angiogenin, VEGF, and other cytokine factors. In other words, those who regressed had higher levels, and those who progressed had lower levels, and we could predict this way before it actually happened. In this final animation, you're seeing a rise in the level of these factors that is happening just before the blood vessels reach the ora serrata, which is a mature retina. Imagine predicting this before it actually matures. This study brings out a few very important points. For decades now, we've been holding on to the dogma that a preterm animal, not a human, an animal is born with low serum VEGF. We believe for the first time there is a human molecular evidence of that. The study also shows us that even a baby a few days old can have tears, we can actually detect these antigens and actually now correlate to see which baby develops the disease or not. So are we finally looking at a biomarker for ROP? Our institute is developing a point-of-care kit, something like this. You put in the Sherma strip and you get a report, and we are going to integrate this into our rural ROP program, where we screen about 600 to 700 new babies every month, about 2,000 examinations every month. And every single baby who's going to undergo the ROP screening for the first visit is going to have the tear analyzed so that we can better predict their follow-up, maybe tighter the follow-up, and even decide which baby needs closer follow-up because he or she may need treatment. For this Gulbarga baby, we started off our story with, it might mean just 3 visits less. But for the babies of our country, it will mean more than 10 million examinations saved and a chance to predict and possibly prevent ROP blindness. This is what we call translational science, taking a research idea from the lab into our clinic, but most importantly, if it has to really impact, then it must go into the community. And in this case, if we can affect the lives of those 3.5 million babies who are born, then that's really an important contribution we would like to make. Thank you.
Professor VINEKAR, I think it's a very excellent research, but I would like to know what are the sensitivity and specificity that you have found? Because before you jump to the application part, I would like to know that.
Firstly, sir, I'd like to add that when we submitted the abstract, it was 39 infants. Now it's more than 170. It's a cytometric bead array analysis. So sensitivity and specificity has to be viewed a little differently. The guys who make the antigens claim a specificity of 100%. Sensitivity is not truly measured that way. It has a detection range.
Yeah.
Before we actually zeroed in on those 10 molecules, we worked on 26 molecules which we just thought, let's try if it's in the detectable range. And 16 of them fell out. So we've chosen these 10, yes, because they have a role in angiogenic modulation, but also because they could be detected. And these detection rates are within picograms per micro ml. So they're really, really tiny quantities. So all of these, so they don't talk about sensitivity when they're talking about CBA. They're talking about whether it's in a detectable range. And what we are doing now, sir, is we are already developing cutoffs. So we say that if it's between 20 and 50 picograms, this baby will develop mild disease. If it's between 50 and 70, it's severe disease, and then more than 100
So with the clinical correlation, you will have to check how much is your accuracy, or how many false positives you are getting, or how many you are missing. Yes. That is what I'm asking.
So the advantage is there will be no biological false positives because these are beads that directly, in fact, when we talk about VEGF, it's only VEGF 165A. We don't even measure other isoforms. So there's no question of false positives in a CBA. That's the advantage, as against an ELISA, where it's still, of course, based on antigen antibody, but that sits on a plate. This one actually is mobile and goes and fixes, and you actually get the printout in terms of what is actually available. So that's the advantage of using the CBA.
No, but avoiding a clinical testing you are doing. Basically, you are trying to have a alternative to the patient being transported for clinical evaluation. Yes. That I am asking, what is the sensitivity, specificity?
The specificity is 100%, sir. And the sensitivity of all these babies so far, all of them have fallen into that cohort. It is that accurate. So all we need to do is validate on larger numbers, and that's why the community cohort now.
Dr. Anand, that's an excellent study. Only thing is, like the ROP children's, the health is a very, it's an imbalanced thing. It's not something like you do it at one particular point of time, you expect that the child is going to be all right.
Absolutely.
So how do you come to that?
That's exactly the thought that we've had. So in our sub-analysis, we are now looking at their systemic risk factors. Since we are seeing these babies on a weekly or 2-weekly basis in the conventional method, any new systemic risk factor we are also adding. We are now hopefully going to have a risk score saying that if you have A, B, C, D risk factors with this picogram of value, this is your risk. And we are already doing that sub-analysis because, as you rightly said, the confounding factors would be the systemic risk factors, and many of them will actually interfere in the angiogenic process, including, of course, we know oxygen and others as well.
That's an excellent work, Anand. My question comes back to what Dr. Sharma, do you in future see this as an alternative to RETCAM or a clinical exam?
No, ma'am. No, I don't think we'll ever have an alternative to do ROP screening. This is not even, we're not even claiming we have a cause and effect. We're not saying that, hey, we've discovered VEGF to cause ROP. What we're just saying is that at certain levels in the very first visit, we have very, very good accuracies to predict that this baby will actually probably need treatment or have.
This will help you in monitoring the follow-up.
And maybe reducing the number of follow-ups, because it's a huge economic burden and a systemic burden for these tiny babies to keep getting in and out.
It's a brilliant work.
Thank you. Congratulations. I think it's a brilliant work. Maybe it will help get more patients to the referral centers from the community as a screening tool. As a screening tool, if you screen from them and they have more positives over there, the likelihood of them being referred, or I mean, the channel becomes more stronger.
That would be very nice. If our neonatologists believe that sending a baby could help prognosticate better, then that would be the war one.
Yeah, because ophthalmologists are doing their share, but
We need pediatrician support.
This is really a good paper and a good finding. When you have reached 170 cases, have you noticed any difference?
No, sir. They're consistent.
Exactly.
All our results are consistent. Yeah.
So
Our
at
statistical, the power of the test has gone up, but it's consistent.
No, but at 170 now, are you able to take a wild guess like how
Yes,
many
sir.
visits you can cut?
Not how many visits yet, sir. But what we are able to do now is categorize them into cohorts. Less than 50, 20 to 50,
like
70.
Good.
Thank you, sir.